So we go on to the first set of talks, which is irregular astigmatism post-keratoplasty and keratoconus. And discussing these are our speaker is Dr. Charuta Puranik, who's a senior consultant ophthalmologist, is a cataract and a refractive specialist from KIMS Hospital, Secunderabad, and her talk is going to be monofocal IOL is the way to go. Now, contradicting her is going to be Dr. Shreya Ramurthy, who's a consultant cataract, cornea, and refractive services at the Eye Foundation Group of Hospitals. And he is going to say that toric IOL is the answer in more often than not in keratoconic or eye or in post-keratoplasty. And giving her expert viewpoint on this is, again, we will be calling Dr. Prema Padmanabhan. And so on to you, Dr. Charuta, let's hear from you about why you feel monofocal is the way to go.
Good evening, everyone. So thank you for the opportunity, Dr. Chitra, and it's a very interesting and challenging topic. So I'm going to delve right away into the topic. So I'm going to start off with a case. This is a 24-year-old female patient who presented to us with the left eye like this post-DALC, 6 years post-DALC done for keratoconus in some other hospital. She had also suffered from microbial keratitis. As you can see, there is a scar over here. And this is her refraction in the left eye, -10 sphere, -3 cylinder at 25 degrees axis. With this power, she was correcting to 612, but obviously, if you can see, there is an isometropia in both eyes. So we went ahead, we did, she also had a steroid-induced cataract in the eye. And we went ahead and did the IOL master, which is showing a difference in the keratometry values, which from the topography scan. And we also did the specular to complete the evaluation preoperatively. Based on this value and based on the keratometry values that we had during refraction, we decided that the spherical equivalent power was somewhere between 2 and 10 because of the axial length, considering standard K and also the K that we took from the IOL master. So therefore, a spherical equivalent power of plus 7.5 was taken in between. And we had obviously counseled the patient that she would have a refractive surprise. I planned a sclerocorneal tunnel incision in order to create a surgeon-induced astigmatism of 1.5. And then at the end, this is her last follow-up. You can see there is a piggyback IOL of the toric IOL along with a sphere of +2. So totally altogether, post-op day 1, she was 6'9", and now 1 month post-op, she's 6'6" parts. So this is, I'll come back to this case later on. This is to say that the grapes are not sour. Now I'll come to the other half, that irregular astigmatism in keratoconus, what are the facts that we know? And Dr. Chitra has asked me to keep it to a very theoretical and evidence-based talk. So here goes the review of literature that we have. Now we know that IOL power results of cataract surgery in keratoconus have long been suboptimal. And with significantly fewer patients achieving within 1 diopter of the intended refractive target, even with a monofocal lens. And a hyperopic shift following the surgery is also commonly described, particularly in patients with more severe stage of the disease. And we have a myriad of challenges which we face while selecting a suitable lens. That is standard formula, IOL calculation formulas predict effective lens position based on the parameters of a normal eye. Whereas that cannot happen in these cases because of the abnormal relationship between the anterior and posterior corneal curvature, the varied anterior chamber depth and axial length, and also standard keratometric indices depend on the predictable ratio between anterior and posterior corneal surface, which is progressively being disrupted in keratoconus. Next is the question of which K. So simulated K value is actually derived by taking radius of anterior corneal curvature and a standard keratometry index of 1.3375. It assumes a fixed ratio. In keratoconus, this ratio is altered as said before. Now, Kamia et al. Calculated the total corneal refractive power, TCRP, using ray tracing methods. And this considers both anterior and posterior corneal surfaces in keratoconus, and he compared it with SIM K value. As you see in the graph, the degree of variation between SIM-K and the TCRP values in keratoconus eyes is markedly high as compared to those in normal eyes, and this difference becomes more evident as the disease progresses. So likely the cause of hyperopic refractive error post cataract surgery in keratoconus patients is due to the overestimation of this TCRP. Another to add to that is the decentered cone, which doesn't coincide with the visual axis. What else? So rotational stability is actually a major endpoint analysis of the toric IOL. And it greatly depends on capsular bag size and axial length and associated myopia. So theoretically, all patients with keratoconus who have axial myopia or should be actually prone to IOL rotation, although there is no case report which is actually reported this. Now, residual astigmatism can be produced due to rotation of the toric IOL post-surgery. Again, let's look at the pooled studies which we have. So this is data from 2020, and Kane et al. have studied 147 eyes of 147 patients for all stages of keratoconus, and the keratoconus Kane formula actually did very well in all stages. And to avoid hyperopic result, which was mentioned before, they suggested some corrections also, that is in mild to moderate keratoconus. There should be no correction in the Kane keratoconus formula. In the moderate, you can target myopia of 0.75 to 1.5, and for severe cases, -2 to -3 should be aimed. Now, this is the only study which has actually compared normal IOL formulas with IOL formulas that are specially designed for keratoconus patients. And with all this in mind, we are only talking about monofocals here. Now, we have some latest data from 2023 again, wherein Ling et al. Have upped this number and compared 160 patients. The accuracy and outcomes of different intraocular lens power calculation formulas in keratoconus with monofocal IOLs and with toric IOLs. So in these 160 patients, 136 received the non-toric lenses and 24 received the toric lenses. That is, the lesser number itself says their preference. However, if we look more carefully at the data also, the patients who underwent the surgery, in both the groups, the mean refractive error, predicted refractive surprise was not different between the two groups. That is the first and foremost pointer. Next, if we go to see the subgroup analysis, in all the subgroups also, there was not much difference between the average post-operative spherical equivalent and the final CDVM. More notably, if you can see, 7 of the patients were who received the monofocal IOL stopped using the RGP after the surgery, whereas all 3 patients who got the toric lenses continued their RGPs even after surgery. Another interesting, I was searching for some interesting data, that is in keratoconus, what is the contrast sensitivity or higher order aberrations. And this is a group, Sneer et al., who have assessed correlation between wavefront aberrometry and contrast sensitivity in patients with keratoconus. And they have also sub-analyzed patients with keratoconus having 0 log mark. So there were significant differences between groups between higher order aberrations for trefoil, total coma, trefoil, and spherical aberration. The contrast sensitivity is again significantly lower in keratoconus compared to control groups, and significantly lower in keratoconus with a visual acuity of 0 compared to the control groups, which means that even if you have a 6/6 vision acuity, your contrast and your higher contrast is going to be lower than somebody with a normal, and your higher order aberrations are probably going to be higher than somebody with a normal eye. So why is this important is, this is another case series wherein the changes in astigmatism and corneal higher order aberrations after phaco with toric IOL implantation for mild keratoconus was checked, and they showed that the corneal higher order aberrations were changed from 0.47 to 0.52 post-operative, which is not statistically significant, but however, it was a slight increase in the HOA. Now, if we again see that what happens if you make a mistake, if there is a slight rotation or if there is a slight error in calculation, what happens? Residual astigmatism, if it is greater than expected, then aberrations tend to be higher. So this patient is obviously going to be intolerant to higher order aberrations already from beginning, and you are also subjecting him to a probable increase in the HOA. Again, contrast sensitivity. This is a repeat thing. Now, what else do we not know? What is the comparative value of such measures, that is contrast and HA toric versus monofocal in keratoconus? We don't know what is the level of spectacle independence comparative value between these two. I didn't find any literature about quality of life and any literature about secondary interventions that these patients underwent, which would be something that I would want to know. Coming back to the case 1, and this is what the questions that were asked to me, and which I obviously didn't have an answer from the relatives of the first patient. Will the graft reject? What will happen if the graft rejects? What will happen if there is another infection? And this is post keratoplasty patients. Obviously, even though I put a piggyback lens, the patient is now 6'6", and another keratoplasty was definitely not justified in these patients. But these are the variabilities that the patient will face in future. So to conclude, there is no change in the corrected distance visual acuity between toric and non-toric. There is a lesser margin of error allowed in the toric IOLs for keratoplasty. Post-keratoplasty fate of the graft is a challenging situation, and further studies are required for real-world scenarios as to how the patients feel after a toric versus after a monofocal lens. Thank you for your patient listening.
You're on muted.
No, Dr. Charuta, that was a very crisp talk, very informative.